All right, we finished in our last video talking about factors affecting the expansion and relaxation or exhalation of the lung. So lung recoil is the ability of the lungs to bounce back to their resting position, so that helps with exhaling. And surfactant is something that helps overcome the surface tension within the alveoli due to water molecules. So that tends to want the lungs to collapse, that surface tension due to water molecules. So surfactant is a special substance secreted by cells lining the alveoli that helps to overcome that, and that helps keep the lungs expanded. So lung recoil elasticity brings the lungs inward, allowing the lungs to go inward with exhaling. So we do need some amount of lung recoil elasticity and surface tension to allow the lungs go back to their resting state. But surfactant is something that helps them to expand so we don't have too much surface tension, which would eventually lead to lung collapse if it got too high in that surface tension due to those water molecules. Pleural pressure, I already mentioned, is a negative pressure, and it allows the lungs to expand. Anytime we puncture through those membranes around the lungs, the visceral and parietal pleura, we destroy that negative pressure, and that can lead to what we call a pneumothorax. So that's where there's air in that pleural space causing that negative pressure to become positive and equal to the outside air, and then the lungs collapse. Compliance is the ability of the lungs to move outward. So because of the pull of those membranes, the visceral and parietal pleura, and the fact that the parietal pleura is attached to the lung or to the thoracic wall, when the thoracic wall goes outward with the contraction of those external intercostals, the lungs go with it. So the ability to inhale and expand the lungs is increased because of the concept of compliance, the ability of those lungs to move with the thoracic wall. And we already mentioned surface tension is the attractive force of water molecules that want to form a water droplet and collapse the lung. So we don't want too much water in the alveoli, just the right amount to allow exhalation to occur but not lung collapse. So keeping the lungs expanded to move outward, we have to pay attention to the fact that we have compliance and negative pleural pressure. This says lung recoil. Lung recoil is not what keeps the lung expanded. That actually allows the lungs to collapse after they've been expanded. So you need to change this. This should actually say compliance rather than lung recoil, because lung recoil is what allows the lungs to collapse after they've expanded when we exhale. So this should say compliance, not lung recoil. So again, compliance is the ability of the lungs to move with the chest wall when we breathe. So sometimes the lungs don't want to move with the chest wall when we inhale. If the lungs are stiff due to pulmonary fibrosis, if there's a lot of water around and inside the lungs, that's going to increase the surface tension. That's going to prevent the lungs from moving outward because there's going to be too high a surface tension. And then respiratory distress syndrome, that's when babies or people that were born premature have damaged lungs that are not very pliable, and as a result they don't move with the chest wall. So again, when we talk about compliance, it's the ability of the lungs to expand and move with the chest wall. So when we look at how air moves in and out of the lungs, it has a lot to do with pressure and volume changes. And when we look at pressure on the outside of the body, that's equal to 760 millimeters of mercury. That's atmospheric pressure. But if we just set that number equal to 0, so we'll just use the numbers outside the parentheses. So if the pressure outside is 0, then we know that the interpleural pressure, the pressure in this space, intrapleural pressure, is always negative because of the pull of the thoracic wall, and the lungs elastic recoil, wanting them to move inward, makes a little stretch in this space, which makes it a -4 value, and it's always negative. And we also have lymphatic vessels draining this space, so there's no buildup of fluid, so that leaves it always a negative pressure. And then we have the pressure inside the alveoli equal to 0 between breaths. So there's no difference in pressure between breaths outside the lung and inside the alveoli, so we set that equal to 0. So this is, again, just between breaths. But in order to move air in, we need to drop the pressure because air always moves from high pressure to low pressure. So if we want air to move in the lung, we have to drop this pressure by changing the volume of the lung, and that's the job of the muscles that control breathing. So we'll watch this little animation here. All right, maybe not. I'll have to go outside of this and let's see, McGraw-Hill.
At the end of expiration, barometric air pressure and alveolar air pressure are equal.
So there's no movement of air when the pressure inside the alveoli is equal to the pressure outside the alveoli, out in the air.
Therefore, no movement of air into or out of the lungs takes place. Inspiration begins with contraction of inspiratory muscles to increase thoracic volume.
So that volume is increased by the diaphragm contracting and the external intercostals pulling the ribs up and out. That's going to increase the volume. When we increase the volume of a space, that's going to drop the pressure, and the pressure is going to be lower in the alveoli, and that's what's going to allow air to flow into the lungs from higher pressure outside the body to lower pressure in the alveoli.
This results in expansion of the lungs and an increase in alveolar volume. The increased alveolar volume causes a decrease in alveolar pressure below barometric air pressure, and air flows into the lungs. At the end of inspiration, the thorax and alveoli stop expanding. Airflow into the lungs causes alveolar pressure to become equal to barometric air pressure.
Whenever we have pressures equal, that's going to prevent airflow because air flows only from high pressure to low pressure. So once there's enough air in here that this rises up to be equal to atmospheric pressure, airflow stops.
Because the pressures become equal, no more movement of air occurs. During expiration, the volume of the thorax decreases as the diaphragm relaxes and the thorax and lungs recoil.
So the external intercostals relax, the diaphragm relaxes, and the volume decreases. As the volume decreases, that increases the pressure here higher than atmospheric pressure, so air flows out of the lungs. So exhalation is a passive process, and that's a key thing to remember. All we have to do is turn off the impulses to those external intercostals and diaphragm to relax the chest wall and decrease the volume to increase the pressure.
This results in a decrease in alveolar volume and an increase in alveolar pressure. Since the alveolar pressure is now greater than barometric air pressure, air flows out of the lungs. Air continues to flow out of the lungs until alveolar pressure becomes equal to barometric pressure.
Okay, so again, we have to have a change in volume before we can change the pressure. So when we inhale, we increase the volume, which drops the pressure. Air flows in until they're equal, and then as those muscles relax, we decrease the volume, which increases the pressure, and air flows out. So it's all about volume changes getting pressure to change. A couple of clinical conditions we see with the lungs that's going to affect the ability of air to move in and out is one is called a pleural effusion. That's when fluid enters into the pleural space, and then people have fluid in and around the lungs, making it very difficult to breathe. And pneumothorax, like we said, is when there's some type of puncture in the pleural space, and that can be caused by surgery, broken ribs in a car accident, a stab wound, gunshot wound, or sometimes it just happens with people that are smokers or people that are very tall and thin. They just have issues with lung collapse and pneumothorax. This is what a pleural effusion looks like. There's fluid in and around the lung, causing it to totally be whited out in this x-ray. Here we can see a little haziness of the lung tissue, but the lungs are filled with air, so we should be able to see just kind of a hazy lung tissue with a lot of air in there. And here we just see it totally whited out with fluid. That's not normal. Here's a pneumothorax, which means the lungs have collapsed, or on this side it's collapsed. Here we can see a hazy inflated lung. Here it's quite black because there's no lung tissue picking up a little bit of haziness, and the lung is actually here along the body wall. So this is a pneumothorax resulting in lung collapse. So we can test lung function by using a spirometer and measuring the air coming in and out of the lungs when a person breathes. So this up and down pattern here is called tidal volume. It's air breathing in and air breathing out. This is quiet breathing. We call this tidal volume. About 500 in and about 500 out. When someone's at the top of a normal inhale and then they inhale all the way to the top as much as they can, we call that the inspiratory reserve. So when a person takes a drag on a cigarette or takes a big inhale before going underwater or blowing up a balloon, that's this inspiratory reserve volume. Then we have a little bit of extra exhale volume beyond normal exhale. We can exhale a little further. We call that the expiratory reserve volume. And that's when you would cough or laugh or just blow all the air out of your lungs. That is that extra volume that we have there. But normally we should just be kind of in this quiet zone when we're just quiet breathing, and that's called the tidal volume, which is about 500 mils. So we can look at these measurements over time and see if a person has progressing lung disease. So we talked about those. One thing about residual volume, there is a certain volume in the lungs that we can't blow out because that's the air that keeps our lungs inflated, and some of the air is in our airways that we can't blow out in our deeper airways. So that's called our residual volume. We always need some amount of air available for gas exchange and keeping the alveoli open. So we also have capacities, which when we add volumes together, we get these capacities. And you'll learn more about this in advanced A&P, so we're not going to test you on the capacities. So don't worry about, studying that in great detail just yet. So when we look at how gases cross the alveolar wall, remember that the alveolar wall is made of simple squamous epithelium. And the pulmonary capillaries that are right next to the alveoli are also simple squamous epithelium. So we have this rapid exchange over this thin membrane, which we call the respiratory membrane, which is made up of the alveolar wall right next to the capillary wall. So we can get oxygen from the alveoli into the blood very quickly and carbon dioxide from the blood into the alveoli to be exhaled very quickly. So we find that carbon dioxide diffuses faster because it has a higher coefficient of diffusion. And that's just a constant, it's just a number based on the chemical properties of CO2. So we don't need to analyze that. We kind of just accept it at face value that carbon dioxide diffuses a little more easily than oxygen does. So that means we don't need as much of a pressure gradient for carbon dioxide to diffuse from one point to another as we do for oxygen. So we're going to see that oxygen has a higher pressure difference, giving it that extra push to leave the alveoli and enter the blood, or to go from the blood to enter the tissues, because we need oxygen ultimately in the tissues to support metabolism. Carbon dioxide, on the other hand, leaves the tissues, enters the blood, is carried up to the lungs, and then it leaves the blood and enters the lungs to be exhaled out, because we know that carbon dioxide is a waste gas from metabolism. So when we look at oxygen, remember that it's moving from alveoli to the blood and then from the blood to the tissues. And again, carbon dioxide is in the opposite direction. So we find that the pressure of oxygen in the blood is less than the air. So the highest pressure for oxygen is always outside the body where it's produced by the trees. And as it enters the body, it's diluted by water vapor in the airways, in the conducting zone. And it's mixed with old air from previous breaths. So we are always going to find the pressure of oxygen in the blood is going to be a little less than the air. So if we look at this diagram here, we can see that oxygen comes in from the outside. The pressure of oxygen in the alveoli is 104. And then it drops a little bit as it's carried back to the heart to be distributed to the body because the lung tissue itself needs a little oxygen. So we see a slight drop from 104 to 100 as it enters the pulmonary veins. Then it is circulated out through the heart, through the aorta and all of its branches to become the systemic arteries. And then it leaves the blood and enters the tissues. So we know that oxygen is always lowest in the tissues because it's constantly being used by the tissues as a result of metabolism. So we're always going to see a push of oxygen out of the blood into the tissues because it's always going to be lower in the tissues than it is in the blood. And that's why oxygen diffuses out of the blood into the tissues from higher pressure to lower pressure. And when you look at carbon dioxide is always highest in the tissues because that's where it's produced. So it's always going to be pushed out of the cells, high pressure carbon dioxide to lower pressure, into the blood. And then it's going to go back to the heart to be taken up to the lungs to be diffused out. So we're going to see carbon dioxide is lowest in the alveoli, higher in the blood, again to give that push out of the blood into the lungs to be exhaled. So again, the pressure of oxygen in the body is always highest in the alveoli, lowest in the tissues. And the pressure of carbon dioxide is always highest in the tissues and lowest in the alveoli. That provides that pressure change for us to move oxygen and carbon dioxide in the appropriate direction to maintain metabolism. So we have another animation here I want to show.
Fresh air entering the lungs carries oxygen to the alveoli. The amount of gas in air or of gas dissolved in a fluid can be expressed as partial pressure, which is measured in millimeters of mercury. The partial pressure of oxygen in the air within the alveoli is 104 millimeters of mercury. Carbon dioxide that enters the alveoli from the blood causes the carbon dioxide concentration in the air of the alveoli to be 40 millimeters of mercury. Carbon dioxide is continually removed from the alveoli as air is expired. Blood coming from the heart at the arterial ends of the pulmonary capillaries has a partial pressure of oxygen, or PO2, of 40 and a pCO2 of 45. Therefore, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of these differences in partial pressures. Oxygen and carbon dioxide diffuse until there is no difference in partial pressure in the air and the blood. At this point, there is no more net movement of O2 or CO2. Therefore, at the venous ends of the pulmonary capillaries, the PO2 in the blood and alveoli is 104, and the pCO2 in the blood and alveoli is 40. Some oxygen was removed from the blood to nourish lung tissue. Therefore, the PO2 in arterial blood leaving the heart is 95. Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures.
Now you'll notice in your textbook it shows the PO2 in the capillaries is 100. That's just a minor difference between textbooks, so don't worry about that. 95 or 100 is not very significant.
At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the pCO2 in the blood is equal to the pCO2 in the tissue fluid, resulting in no more net movement of O2 or CO2. The blood now carries the O2 and CO2 to the lungs. In the body, all of these exchanges occur simultaneously.
All right, so we will pick up in the next video talking about how oxygen and carbon dioxide are transported within the blood.